Hello, everyone, and welcome to this LSVT Global webinar. We are so pleased to have you with us for this, entitled Got a Challenging Case? How LSVT Loud and LSVT Big Can Help Complex Clients. My name is Heather Cianci, and I am the physical therapy faculty member who is presenting alongside of my speech pathology colleague, Heather Hodges. We are Heather ×2 presenting today, and we are so thrilled to be able to share this information with you about the challenges that you may be facing when you are dealing with a more complex situation. Very briefly, I'll just talk to you a little bit about who we are, but we do have our entire biographies here. As I said before, Heather Hodges is a speech language pathologist. She has been a part of Dr. Lori Ramig's research team since 2004 and works as a consultant, expert clinician, training and certification faculty, as well as our CE administrator for LSVT Global. And again, my name is Heather Cianci, and I am a physical therapist, and I work out of the Dan Aaron Parkinson's Rehab Center, which is at the Pennsylvania Hospital, part of University of Penn, Good Shepherd Penn Partners. And of course, we just need to talk to you briefly about our disclosures. All LSVT faculty do have both financial and non-financial relationships with LSVT Global. And what does non-financial mean? That means that it is our relationship of having a preference for using both LSVT Loud and LSVT Big as treatment techniques. And our financial relationship does say that both myself and Ms. Hodges are consultants for LSVT Global, and we do both receive a lecture honorarium. So just a little bit about the logistics of this webinar. Right now, we do have all of your microphones muted so that we don't have any disruptions from wherever you're coming in from. We're going to talk a little bit about how to ask questions, but briefly, the best way is when you have a question, just simply go ahead and chat in that chat box. Go ahead and type your question in there. We do have a link to the handouts that you are able to download and print yourself. And please do, at the end or the conclusion of this webinar, take a moment just to fill out the survey that we have. It truly does help us to be able to know what you enjoyed and what we could do better and some of the things that you're looking for in webinars. And then I'll touch briefly about CEUs. So this LSVT Global webinar is not ASHA or state registered for CEUs, for speech, PT, or OT, but you may be able to use it as a self-reported CEU. So if you are PT, OT, or speech, you are a professional now, and you would like to self-report your activity, please do send us an email at webinars@lsvtglobal.com. Go ahead and request your certificate when you complete the full hour of this webinar, and we will send you out a certificate which will include your name, the date, and the duration of the webinar. Remember that the licensing requirements really do differ state by state for the CEUs, so you will have to take it upon yourself to check with your state agency and find out whether you can use this for a CEU activity. And we do ask that you fully attend this 1 hour in order to receive the certificate. Our objectives for this are really, upon the conclusion, is that participants will be able to identify at least 3 possible etiologies underlying the more complex LSVT Loud and LSVT Big cases. We hope that you'll also be able to explain ways to adapt LSVT Loud for these complex cases, as well as ways to also adapt for LSVT Big. We do want to mention that when we talk about increased complexity, that we have hosted a number of webinars previously that might be very helpful for you, where you can take a deep dive into some of the topics we're going to be talking about. So one of them is talking about how to improve function and quality of life in individuals with more advanced cases of Parkinson's. We have one that also talks about treating those individuals in real detail with the atypical Parkinsonisms. We also have another one dealing with deep brain stimulation, and then also using intensive therapy for pediatric cases. So how does LSVT help with that? So we wanted to start off with talking a little bit about, what is LSVT if you are new to this, and what is unique about it? Well, the LSVT stands for Lee Silverman Voice Treatment, and this is both a speech therapy under LSVT Loud and a physical and occupational therapy technique under LSVT Big. These are both standardized therapy protocols, and the dosage and method of how we deliver these treatments is truly based on 30+ years of scientific research. Miss Lee Silverman was actually someone living with Parkinson's disease, and through her work with Dr. Lori Ramig, those so many years ago, and the philanthropy of her family, the research was being able to continue to be conducted and sort of leading us to where we are now. It is really important to know, though, that both LSVT Loud and LSVT Big do need to be provided by certified clinicians. And that means that if you are someone living with Parkinson's disease or an atypical Parkinsonism, you're looking for someone who has completed the certification training, who understands the full protocol, and who really is appropriate to do that. Not everyone can provide this treatment. The other nice thing, and why LSVT both Loud and LSVT Big are unique, is that it considers not only the motor symptoms of Parkinson's disease, but also the non-motor symptoms. And many of my clients over the years have talked about how disabling and troubling the non-motor symptoms can be. So it's really a comprehensive way of looking at treating the entire individual in a way of providing functional speech and mobility. The also wonderful thing that I personally love about LSVT is that it is an individualized one-on-one treatment program. It's very intensive, and it works on things that simply matter the most to the person living with Parkinson's. We know that Parkinson's can make movements much slower and much smaller. You hear those terms, hypokinesia and bradykinesia, and it can also make the voice softer. And what we do through LSVT Big and Loud is to counteract this by helping that individual to train bigger, more normal movements and a louder, healthier voice. So it is a quite unique program, and we're going to talk a little bit more about the things that go into making it unique and why it could be helpful for you if you're someone living with PD or if you are a clinician attending this webinar, how it can help you with more complex cases. One of the things that people, I think, sometimes are afraid of when they hear that this is a quote-unquote protocoled treatment, that it has a standardization factor to it, is that they think that it's not moldable, that you can't change it to what you need for the specific needs of your individual patients. And yes, it is a standardized protocol, but it is quite individualized. And that means that not everyone is going to be doing this the same way. They're not going to have the same goals. They're not going to have the same needs. Some people are going to be able to do more repetitions. Some people are going to be able to do less. And we can adapt this or progress it to actually make it much more challenging in order to really meet those needs across a range of disease severity and any kind of impairment. So it could be from someone who is newly diagnosed to someone who is moving into those later stages of the disease. So when I talked about it before, what sort of makes LSVT Loud and LSVT Big unique, one of the first things is our target. And our target is amplitude. And we look at it from two standpoints. We're looking at the loudness for the voice, and we're looking at the bigness for the body. So we know that folks with Parkinson's disease often have a voice that is much too soft and the movements of the face much too small. Now, when we take that single target of pushing someone to actually talk louder, and we drive the effort and how hard they're working, that's where we increase the amplitude and we get them to a louder voice volume, but it is not too loud. It actually ends up putting someone in a healthy vocal loudness. People will feel like it's too loud, but it's actually just right. And then when we look at it from the standpoint of movement, so if we're considering walking, we think about the small kind of shuffling steps and maybe that bent posture that can happen with Parkinson's. Again, if we take that single target of bigness and we get people to really drive that amplitude, we get them into those bigger movements, we actually now have healthy amplitude. So when you take that one single target of the amplitude, it triggers activation across the whole motor system. So a lot of times when we have people who are working with LSVT big and we're driving their big movements, we'll notice that they start to talk louder. And the same thing happens for our speech language pathologists. When they're driving that voice, sometimes they notice that people are sitting up bigger and that they're moving their body in a much bigger way. So like I said before, amplitude really does act as that trigger. And we as the clinician are there to really help shape and model. And that means we are the mirror for the patient. We're showing that person what it looks like, what it sounds like, and we're shaping them by touching them and helping them by really getting that normal loudness with a healthy vocal quality, or getting the normal amplitude movement, again, with healthy quality of movement. The other thing that is unique is that our mode is really intensive and high effort, meaning that we really do push people quite hard, harder than a lot of people think is possible for them, but really surprisingly for them has great impact. So the intensity is across all of the sessions. So, what we're talking about here is just the minimum doses for the efficacy. We have lots of people who actually do more. So on the minimum dosage, we're looking at 4 consecutive days a week for 4 weeks in a row. So we're looking at a total of 16 visits plus that initial evaluation. And it does take a full 60 minutes. So you are working hard with your therapist that entire time. I mentioned before that it's one-on-one individual therapy. This is not done in a group, and that really helps the therapist to make sure that they are focusing on the particular things that you, as someone with Parkinson's, wants to work on, and you as the therapist are helping that person to figure out. And again, we don't just work with the person while they're with us in the clinic. We also assign daily homework practice and carryover exercises. So that entire month, the 30 or 31 days of the month, they are working hard. And I mentioned this before, but again, those clinicians who are providing that are certified clinicians in LSVT Big for PT or OT, and they're certified SLPs for LSVT Loud. The other thing that's really unique about LSVT is that our overall goal is something called calibration. And we explain calibration like this. If you set your thermostat at home to say 68 degrees, but you walked into your house at the end of the night and it was absolutely freezing, that temperature did not get warm enough, well, then that thermostat is not calibrated. If you set it at a certain temperature, if it's calibrated, that's what you should feel. And that's what we're talking about with people with PD. We're addressing the barriers to generalization, meaning how do we get people to feel that they need to move bigger and feel how to talk louder, but that it's at that healthy stage of loudness and bigness. Well, we work against that sensory disorder. We're teaching people how to feel and to understand their bodies better, and then teaching them how to internally cue themselves. This is what I need to do in order to walk better. This is what I need to do in order to talk better. And then it also really does work against the neuropsychological problems that happen with PD. So people can feel depressed, they can feel like they have low vigor, low energy. Apathy is also common. And when you work with a program that's really a lot of fun, that's very active, and that you see change quickly, and that you're working on things that are important to people, it really does help with motivation and setting in new habits of what to do. So the overall goal into therapy is to incorporate those multiple principles that drive neuroplasticity. And neuroplasticity simply means brain change. What are we doing to make that brain work better? We talked before about how LSVT, both loud and big, works on the intensity, how hard we push people, but we also want to make sure we're making things complex so that we're challenging people, we're working them to their potential. The repetition is very important. That's one of the main things for driving brain change, is doing something over and over again and really learning the right way to do it. The word salience means it's something that's important. I said this before, but again, I'm going to repeat it and say it again so that you're getting neuroplasticity. If it's not important to the person, they're not going to want to do it. So we really do need to work together for those goals of what's important to that person to be able to do better and to have a great quality of life. Timing is always important. We love to see people soon after their diagnosis, but we know that that isn't always the case. We do know that even when we see people mid-stage to later stage, we can still have an impact. And specificity, that means that whatever you're having trouble with, we need to work on. If it's getting up out of a chair, we practice getting out of a chair. If you want to be able to stand taller and project your voice better when you are giving a presentation, if you want people to hear you more clearly over the phone, those are the things that we're going to work on with you. And that is the basis of all we do to really help that brain change happen. So these are some examples of using amplitude as a source. And you can see here with the first one with Parkinson's disease, when things are hypokinetic, when we're bringing them down, we see that people aren't giving as much effort, that there's more small movements. And the rationale for the big, again, for the LSVT, I should say loud and big, is to really increase that amplitude of the output so that we can get more vocal loudness, we can get better speed of movement, everything's working bigger. When you're looking into the population of people who are maybe having more issues with spasticity, some of the things you see is the weakness and the limited range of motion. But again, using LSVT to drive the amplitude again really can help. And the last two down there, I'm not going to talk in detail, but you can always go back and look here. Those individuals with ataxic movements, as well as the flaccid movements, you know, there really is a rationale for using the LSVT protocol with this. So now let's take a moment and talk a little bit about how we address the complexity of advanced Parkinson's disease.
Wonderful. Thank you so much, Heather, for that framework and overview of the programs, of what we are addressing, and the nuances of the therapy, and what a very dynamic and exciting treatment it really is. And, you know, when we talk about the complex cases today, we start with those with advanced Parkinson's disease because they do present with their own unique challenges. So when we are talking about advanced PD, it might be helpful to review the stages of Parkinson's disease. And so this slide highlights the modified Hone and Yahr scale. Now, much of the research on LSVT has been on individuals between stages 2 and 3, but clinically, we absolutely treat all stages from 1 to 5. And so thinking about advanced Parkinson's, we're really looking at stage 4 and stage 5. The physical disability may be more severe. Patients may or may not be able to walk or stand without assistance, or perhaps they are wheelchair bound or bedridden unless they are aided. So thinking of this as your framework, let's discuss more about the advanced Parkinson's presentation. So as folks are referred to you and you notice in their medical chart, you see stages 4 and 5. Before you meet those patients, here are some of the characteristics that you might be seeing. So with those with advanced Parkinson's, their symptoms are going to be more complex. Their daily life is going to certainly be more impacted. They are going to have cognitive complications. Not all of these and not all of them will exist for each patient, but you may have your patients experiencing hallucinations. Dementia may be starting to play an impact, which is important to address those cognitive changes when we're, you know, dealing not only with in-treatment challenges, but also the challenge of cognitive changes, remembering to do homework and carryover, as Heather mentioned, is part of the protocol. Patients may also be more apathetic, which impacts motivation. Depression and anxiety are often present, and so that's going to be some of those neuropsychological changes that we're up against for generalization in that calibration example. Some may even be experiencing psychosis. From a motor standpoint, we're going to be seeing patients with increased rigidity. As mentioned in the Hoehn-Yahr scale, you're going to see increasing immobility. That, of course, is going to be impacting people's movement, their daily life, how much they're getting out and about, how much they're talking, how much they're interacting with their environment from a mobile standpoint. But it's also important to point out that increasing immobility can cause issues with skin breakdown, contractures, pain, loss of muscle mass. All of these will be important for you to keep in mind, whether you are addressing body movement or voice and speech movement too. And certainly increasing falls will be a part of their presentation as well. We will see that medications can become less effective at managing the Parkinson's patients, and they may have more side effects that result from dopamine replacement intervention, mainly dyskinesias, that kind of writhing, kind of wave-like motion that can occur throughout the body. That's not due to their Parkinson's. It's important to keep in mind that that is due to long-term dopamine replacement therapy. And that can be very distracting and disturbing for the patient. They can have, even some embarrassment surrounding those dyskinesias. When we talk about managing medications, they may have more periods that they really notice times when their medication is on, and they are feeling the effects, and it's helpful. And then they feel more significantly when the medications are wearing off or are totally off. So being aware of those fluctuations. That's not to say that you should only see patients when they are on, when their medications have kicked in, so to speak. We say challenge your patients with some of their appointments being when they're not feeling well, when they are more off, to give them that practice and confidence in these new ways of moving, these new ways of vocalizing, because we have to move and we have to be understood when we're not feeling well. And then again, those just wearing off symptoms. It may not be that the medication is feeling totally not kicked in yet, but just more of that, maybe a more gradual wearing off of medication. Specifically discussing the speech characteristics of advanced Parkinson's disease, you can expect to see more imprecise articulation. When we think of smaller movement, hypokinesia, makes sense that those articulators are just not quite meeting their mark when patients are speaking, and so we get that imprecise articulation. Patients may or may not have vocal tremor. LSVT lab may not totally resolve a vocal tremor, but and in fact, some patients notice it can increase all that effort, all the phonation, the ahs that they're doing. They may find that there is perhaps a little increase in their vocal tremor early in treatment, but once we get some stability, once we get those motor speech systems coordinated, they can just have better general overall control. More disfluent speech, so this may be more of a stuttering-like behavior where you might see initiation issues. It kind of gets blocked up on the way out, kind of like that. Inappropriate silences where you see them trying to talk or phonate, but it's not coming out yet. Hyperfluent, this is sort of a compulsive, really effortless repetition of words and phrases, may or may not be marked as being palilalia, and this may be presenting itself against a background of increasing rate and loudness. So as they are having this more compulsive speech, this repetition, you may find that their speech is becoming faster and they're becoming louder. And word and phrase repetitions, as a heads up, are more likely to occur at the end of an utterance. We also see in these patients increased time that is needed for them to process information and respond. So as you're asking these patients questions, or you're presenting a speaking situation, an off-the-cuff question, for example, don't be surprised if you need to just give them more wait time. Stay quiet, try not to talk for them, don't interrupt them. They heard you. They may not be even visibly responding to you, but they certainly are just in need of that increased wait time. So be patient, allow for that processing time so that they have a chance to respond. And with that, I'd love for my colleague, Heather, the Heathers, to present more about the motor characteristics of those with advanced Parkinson's.
Great, thank you so much, Heather. So as Heather was talking about the changes that go forth with the speech system, they're not unlike some of the changes that happen in advanced PD, with things that you're going to see motorically. That slowness doesn't just impact the rate of speech sometimes and the low effort, those kinds of things. It impacts lots of things. So you start to see increased severity, more of that bradykinesia, right? That slowness of movement, the hypokinesia, the smallness of movement. And then unfortunately, we do see an increase in rigidity, and that can impact range of motion, the ability to really function in a safe or an independent manner. Freezing of gait, unfortunately, in advanced PD can be quite disabling. You can have times where people just have a complete inability to even initiate movement with getting up out of a chair, or it may be that they're moving along, they come to some sort of a freezing trigger, perhaps it's a doorway, it's a tight space, and they get into complete akinesia where they can't move at all. Difficulty walking definitely is something that we see with advancing stages. This is where folks, the difficult way of being able to use a device is just going to be more challenging for them, not just motorically, but also sometimes cognitively. And this is where we're going to see folks who are probably less mobile. They're spending more time in bed, more time in a chair, and probably primarily using a wheelchair for most of their mobility. These folks also too, with just the amount of difficulty they're having with mobility, the lack of safety, the increase in the number of falls, they're just not going to be able to live on their own. They're going to need help in the home. They're really going to probably need to move into a care facility if the family's not able to help them, or home health aides. And it's just not with mobility, but it can be with all of the ADLs as well. And, this loss of independence for people can be very traumatic and very scary and frustrating. The need for assisted devices really increases where people probably are needing tub benches. They may need something as a gait belt to help even with transfers. And lastly, there we talk about the worsening of posture. This is something that we see early on in Parkinson's disease, and without really good effective treatment and awareness of trying to work on it, the posture really can move much forward into that flexed position. And although we have those motor symptoms, I had mentioned before about how the non-motor characteristics of Parkinson's itself, but even more so in advanced PD, can be really, really difficult for folks. People can get into stages of psychosis. They can be dealing with hallucinations. Those could be auditory, where they hear things. They could be visual. Sometimes people even have smell and taste hallucinations. This can be very unnerving and scary, not only for the person living with PD, but also the care partners. There is also increased rates of depression, anxiety, and apathy. With apathy, that drive or that motivation or that desire to do something, to find pleasure in something is so reduced that it can really lead to even further problems with mobility. Underlying sleep disorders, where people are not getting good quality sleep at night, where they may be having sleep attacks during the day, maybe napping too much at day, maybe having problems with sundowning, with cognition. On top of that, autonomic dysfunction can be really problematic. These folks can have real issues with bowel and bladder, as well as issues with thermoregulatory ability, so feeling too warm, too cold. And then one of the most problematic is orthostasis, where they have that sudden drop in blood pressure that can lead to falls. Pain can become more problematic as well when there's less mobility, there's less fluidity of movement, more of that rigidity. And then unfortunately, the longer folks live with PD and advance through the stages, the more likely they are to have an experience with dementia and other sorts of issues. You know, a little bit about what Heather talked before about with it. It takes a little bit longer, and it might take a lot longer for people to actually process what they're doing. That inability to even attend to what's going on and to stay focused, they could be very distracted by what's going on around them. So there's a lot of challenges that do present both motorically and non-motorically with the advanced stages, but it's something that we as clinicians, whether we're doing LSVT loud or LSVT big, need to know how to deal with and see how we can help our folks to still have a good quality of life. And with that being said, I am going to turn it over to Heather Hodges now to talk about the atypical Parkinsonisms.
Thank you so much. And so with atypical Parkinsonisms, there will be some overlap that will be applicable to the advanced Parkinson's that we just spoke about, but there certainly are differences in how they're going to be presenting, certainly with speech deficits. You may also see differences in motor presentation from the LSVT big side of things. But when talking about atypical Parkinsonism, we may be thinking about progressive supranuclear palsy, cortical basal degeneration, multi-system atrophy. Those tend to be the most common that we're going to be encountering. And so you'll observe in these patients changes in speech and swallowing that occur earlier. They are diagnosed perhaps with Parkinson's to begin with, but then we see these more rapid changes occurring more close to the time to the onset of symptoms and to their diagnosis time. You'll also see that these changes are more severe and that they progress much more rapidly. They may have more of a mixed dysarthria, whereas idiopathic Parkinson disease will be more hypokinetic. And so you'll be seeing now, we would say hypokinetic plus. And most often what that means is a strained voice, impaired fluency, slower rate, or palilalia, that festination of speech that occurs that sounds like a very fast, almost like a fast stuttering style of speaking. You're also more likely to see language deficits in the atypical Parkinsonism population and greater communication deficits that will include initiation of speech being more difficult, slower, more effortful, managing conversations, being able to track what's being talked about, or being able to articulate and respond appropriately. So turn taking might be difficult, and certainly shifting topics quickly will be more apparent as a deficit as well. In some of our on-demand webinars specific to atypical Parkinson's patients, we do have audio recordings for you to listen to the differences between progressive supranuclear palsy and multisystem atrophy. But I have listed for you today what those differences are. I encourage, I think the on-demand webinars are a fabulous resource, and so I would encourage you to be able to do a deep dive into these atypical diagnoses and be able to listen to those clips. But PSP, you will have increased disfluency, slower rate, you'll have these inappropriate silences, deficits more so in their vowel articulation, and you may have a more harsh kind of vocal quality that comes across. MSA will present more so with pitch fluctuations that are not appropriate for normal prosody of speech, excess intensity variations as well, that waxing and waning of loudness, prolonged phonemes, vocal tremor, and this will be more of a strained or strangled kind of voice quality. When we think about the rehab focus in both advanced and atypical Parkinsonism, we want to maintain and improve their physical capacity, just as we do with those with IPD. And so what that means is that we want to improve loudness, their amplitude, voice quality, intelligibility, and rate. In body movement with LSVT big, we want to ensure that patients have safe mobility. We may have more care partner training, and of course, fall prevention is really key for both of these more complex presentations. We want to maintain vital functions such as swallowing and moving safely. Functional communication and functional mobility will be paramount. These will really be your key areas of focus when developing goals with your patients and their family members, when you are developing carryover activities, hierarchy, etc. And you may need more use of external cueing. You may even need use of devices, which we'll talk about a little more in a future slide, as well as augmentative devices perhaps too. We will also be addressing alongside their voice and their movement more of the cognitive issues and or their language deficits. With both advanced and atypical Parkinsonism, we say treat early, get them as fast as possible from symptom onset or time of diagnosis, and treat them often. You're going to be following up with these patients, particularly some of the atypical folks, perhaps every 2 months, 3 months. Those patients who maybe are just more advanced in their Parkinson's might be more like 6 months or 4, but you will be absolutely on the journey with them, treating them early and often through the remaining course of their disease progression. Some of the possible LSVT loud adaptations would I'll kind of break it down by task. So maximum sustained phonation. You may be spending more time as the clinician in shaping and modeling that good voice quality during the ah. This may not be as shockingly beautiful as it is with the IPD folks, even in their first session. These may be more difficult. The duration of the ah may be shorter, and so you may not be doing 15 repetitions, you may be doing 20 or 30. And so looking at the time spent on that exercise, I know in the certification there's sort of a timeline of how long each task takes, so that would be important to look at. They may need more rest periods though too, that initiation being more of an issue, and also just the endurance factor that may be at hand here. Understand that these patients may need more of a rest between their repetitions. In the maximum pitch range, their pitch range might be very reduced. So small movement is okay. There may also be a greater tendency to not start at that modal max ah. They might be starting at a higher pitch, or they might be needing just more time to kind of reset this exercise more frequently. In the functional phrases, one adaptation that we often use is family input or caregiver input to help create the phrases that are truly salient and functional. You may be increasing repetition, so doing it more than the 5 times that's in the standard protocol, because these functional phrases are really going to be key for functional outcomes, for goal attainment for these patients. You will likely increase the number of functional phrases too, so that we're really meeting their daily functional needs. So you might even consider using some of them in part of the hierarchy practice. And so in the blue box, we kind of have those highlights of possible LSVT loud adaptations for you to have handy and at the ready, keeping in mind sufficient time for that slower cognitive processing and response, salient practice, so get input as needed from their caregivers, their loved ones, and continue to include structured tasks and spontaneous speech. Those are some good take-homes for adaptations. In calibration, it might be more challenging, but it remains just as important. Education, the component of calibration that we use, the education component, might be more difficult with those having a cognitive impairment. And when you play back on your audio, the differences between the louder voice and their baseline voice, they may not be perceiving them as easily. Sometimes they don't even completely grasp that that's them on the audio playback. So if you see some signs of confusion or kind of a blank stare, empty nod when you're playing it back, just be in tune with that. The benefits to rewards of improved communication might be harder to establish for advanced or atypical Parkinson's disease. And so it really is going to be even more critical to find those emotionally salient opportunities so that the clients really feel the reward of improved communication. They get that reward from those moments, those aha moments, so to speak. LSVT plus, so what that means in terms of adaptation, for some it is more treatment sessions. You might be seeing them for 20 sessions. My colleague Angela and I recently had a patient that we were seeing, and we did just that, and those extra 4 sessions made just the world of difference. More frequent and continuous follow-up, like I said, every 2 months, 4 months, 6 months. Sometimes they may be doing great, and so you check in with them again a month later, but definitely keep that continuous follow-up going. You may need altered auditory feedback, so perhaps like the speech easy. You may even be considering like a delayed auditory feedback, like a speech vive, or augmentative devices that you may need to supplement. Of course, we still want to keep them communicating through speech and voice, but sometimes they need a little supplementation. Pacing, there's a great pacing video for an individual with palilalia that was in your certification course. It's also on your resources in the website, at the LSVT Global website. And these patients, once you've established loud, you may need additional cues such as loud and fast or loud and clear to help really clear up the speech component right alongside the voice issues. And so now we'll switch gears and talk more about LSVT big helping with atypical Parkinson's disease.
So we know that as physical therapists and occupational therapists, when we're working with individuals with the atypicals, that there tend to be many more issues with falls, with lower mobility levels, and like Heather said, movement through the stages of those disease processes much quickly. So it's really important that we do get to these people soon in their diagnosis. And we really do think that we might be able to help these folks by really continuing to use those principles of neuroplasticity, that by working hard with them, using a lot of repetition, being very specific in what we're practicing to their needs, and making sure, again, that we are doing the things that are important to them, that we really can impact the quality of life. The ways that we are helping folks with that may be different motor learning techniques. We may have to do things a little differently where we're doing more blocked or serial, or for some folks it may be the random practice. So again, that beauty of being with those folks for the 4 times a week really allows you to understand how they learn best. The other thing of being able to use those 4 principles of using that extrinsic feedback, right? Where we as the therapist are doing things to help that person by being the mirror for them, by us modeling what they should do, by shaping them, by actually touching them and moving them into the position. And then again, driving them, getting them to work harder, and then making sure if we can get that to stabilize so that we have them learn how to do it. They repeatedly are learning and they're just going over and over it. And they have a good understanding as to, what's not working correctly and how do I fix that. The other way that we may be able to help these folks with the atypicals is really by promoting improved care partner understanding. And again, because these conditions do progress so rapidly, they do have a higher level of cognitive impact on folks. There is a lot of education that has to go into those care partners and helping them to understand, they may not be able to be fully independent with things, right? If we can get them to use intrinsic feedback and using the principle of calibration to get them to reset that internal program where they can actually tell themselves what to do, that's wonderful. But we do know that with progression of the atypicals, this gets much harder. And that's why we do need to pull in those care partners. Again, we want people to have the best quality of life. So if we can get things to generalize to other activities, other functional mobility or tasks that they're able to do outside of the clinic, that's the bottom line. The bottom line, no matter who we're treating with LSVT big, is function, function, function. So some of the possible adaptations that you might want to think about as a therapist, because you still need to follow the protocol of the 4 times a week for 4 weeks, and you're still going to need that hour session with your people. And I think even with your advanced folks and the atypicals, sometimes you can even need a little longer just because of that cognitive delay. So in order to fit that in, it's okay to do fewer repetitions. It's okay to have the hold times be shorter. It's okay to have people, have something to hold on to, whether that's a countertop or a solid piece of furniture. You can break things down. If I'm thinking about the rock and reach, where we're just standing and swinging the arms, and then we have them stop, hold on, and then just work on the weight shifting. Many of these people will need to use their adaptive devices, so it's a great way to kind of prep them for that. We can always adapt things into the seated or supine position. And it may be that we have to keep things to just one hierarchy, that big thing that's really the most important to them. Heather mentioned this before, but we also do more days of treatment. We're going to use different ways of getting that family and other people around to help, whether it's a home health aide or maybe a volunteer or a neighbor. With less of the cognitive reserve, they're going to need more help. And that's where we can take pictures of things, we can use videos. We have to figure out what's the best way for these folks to learn and to be cued to remember. And we're going to model more, talk much less, because again, we have to keep things really simple and keep them focused. And if we overdo it, we're going to lose them. But in the back of our mind, we have to remember that slowed learning initially is really not a sign that the treatment isn't working. It just may take these people longer to make those gains. In general, these adaptations, like I said, you're going to need much more support. You're going to need that care partner, those family members, they may have to give you their perception on ratings to help determine how much of an impact they're having. We may not be able to make them be 100% independent, but maybe they're able to go from mod assist to just min assist with cueing, and that's easier for the care partner. And we need to make sure that we're training everyone how to cue and how to assist, because we don't want people to get injured. And when they're able to learn things, it's better that everyone's doing it the same way. There's going to be what we call islands of lucidity, where people are having a little more mental clarity. We really want to capitalize on this, but that doesn't mean we don't treat people with dementia who have care partners who can help. Heather mentioned before, although it's best to treat people on their on times, we do need to work with people when they're off, especially if their difficulty is getting up in the middle of the night when their medications are low. Dyskinesias, we cannot make dyskinesias go away. They are a side effect of the medication, specifically the Sinemet, carbidopa, levodopa, but we can have an impact in helping people to possibly control them better. And we know that these folks, it's going to take them twice the effort. They're going to be tired. They may have more treatment sessions. We want to acknowledge the fatigue. We want to validate it and be okay with giving them rest periods. And then think about the treatment location. That's an adaptation. If perhaps someone's too distractible and they can't focus their attention, we need to go into a quiet room. It may be someone has issues with transportation, and it may be better for them to be seen by therapy in the home, or even someone who's more remote. It may be through the advent of using telehealth. When we're dealing with those cognitive concerns, like I said, if you have somebody who's highly distractible and has some real issues with that, you've got to keep them into that quiet room and make it very simple. You may not want the family members around, just so you can really focus on them and have that patient focus on you. Remember, what your body does is what you want the patient to do. So you're going to have to use your body as that mirror and model. Environmental cues are okay. Sometimes people will need a post-it note on the floor to step to, or a sign to tell them to stand big or to step big on their rollator. And when we keep it simple and we repeat it and we repeat it and we do it over and over again, that's where we're going to get more of an impact. And that's where we likely are going to have to go beyond those 4 weeks. And lastly there, when you're done with therapy, that patient is no longer with you, right, all of the time. They're going to need to have that care partner be the coach. So we have to do a really good job of training those people to support them. So I'm going to hand it over to Heather, and she's going to talk to us a little bit about deep brain stimulation.
Great, thank you so much. There certainly are some unique aspects to those patients who have Parkinson's disease and have had DBS placement. And so thinking about the impact of the symptoms on Parkinson's disease, there's a little background here for those of you not familiar with DBS. It is a surgically implanted medical device, and it will deliver electrical stimulation to a targeted area of the brain. And so it will stimulate these specific structures, and in return, it will control unwanted symptoms. And so it can reduce or control rigidity, bradykinesia, akinesia, tremor, and dyskinesia. And the patient can only return to their best on period, their on time. It may reduce the amount of meds needed, which is really awesome for these patients, that they're not having to just rely, especially those who've had long-term dopamine replacement or want to avoid long-term side effects of dopamine replacement. And so when looking at deep brain stimulation of the subthalamic nucleus, the STN, it's important to note that this can lead to depression, apathy, impulsivity, such as hyperactive online shopping or gambling, worsening verbal fluency, and may affect executive function as well. DBS is not as effective on those patients who have more of a gait and balance, postural instability presentation of their Parkinson's versus those who have more of a tremor presentation of their Parkinson's. Some of the complications that may occur are listed here. The ones that are kind of in the blue color family are more so iatrogenic complications that occur during or after surgery. And then when we see some of the like kind of greenish color of the complications that are important to know when you're seeing your patients, they may have more suicidal ideation after DBS. They may have seizure disorder. They might have more fear, an increased fear of falls. And in fact, they have 2.52 times the risk of falling with DBS compared to those who have not had DBS. We will see for many a decline in cognition, and that can be very longitudinal in its dynamics. And there may be possible decline in their speech, in their gait, and in their balance. And so individuals with DBS therapy may have extra ability to move without functional impairment, but they lack the feedback and control to do so safely. So there's a nice website resource here that has more information. It's from the Parkinson Alliance group, and they're a wonderful resource as well. When we think about LSVT big and LSVT loud after DBS, here are some nice take-home points to keep in mind. You may be very instrumental in monitoring and perhaps weighing in with their neurosurgery team in the insurance that they're stable on their DBS settings prior to starting treatment for big or for loud. We encourage you to stay in communication with the doctor regarding any changes in programming that might need to be done that's secondary to what you observe in treatment. So an example of this in the speech realm is patients who have a very high voltage setting tend to have more difficulty with speech, with voice. On the flip side, settings that are very low, you might see more issues with movement. Be on the lookout for balance deficits and freezing. They may persist, and this can include freezing triggers in treatment. So in big, during walking, during functional tasks, during the hierarchy exercises. These patients may need to continue a high need for repetition in order to learn appropriate amplitude, appropriate motor control. So be ready to perhaps reiterate quite a bit. Their movements may be too big or hyperkinetic, and the target of amplitude is sometimes just to learn control of movement versus overriding small movement like we do in IPD without DBS. Speech-wise, you may be observing more severe speech impairments. So trials of behavioral speech treatment might be indicated, or they might need additional or augmentative communication devices. Often we find that an additional week or perhaps more, so that idea of LSVT plus certainly applies to this population as well, as does the need for more frequent follow-up every 1 to 3 months. The placement of the stimulators can have varying effects on voice and speech. And so if it's more of a medial placement, you may observe more strained and tight, or even continuous phonation, even that voicing that occurs on sounds that should be voiceless. Inarticulate articulation, perception of decreased breath support, that they have a breathing insufficiency, and they may be more dystonic and less responsive to behavioral therapy. Those with more of the lateral placement, you may have more monotone voice, flat intonation, faster rates of speech, reduced movement of the lips and tongue, which of course will impact their articulation, especially for those bilabial sounds. As well as those, the alveolar sounds. And you may be observing more hypokinetic with their voice and speech. And so they'll respond very well to LSVT loud, but they may have more fatigue as well as some apathy. A very different take on complex cases, we're going to look at the pediatric application of LSVT loud. And here we do target treatment, we target amplitude. And the reason for that and why we do that is because if we think back to loud as a trigger, voice and amplitude as a trigger, and we see that really nice spread of effects across coordinating the entire motor speech system. And so it's been really exciting to get research as well as clinical insights into this. And, you know, when we think about why, it's because communication is important. There are common communication themes from the children and parents on interviews for kids with dysarthria consequent to cerebral palsy. Some of those include that they really want to be socially accepted, and so their first choice is to use oral communication versus like an augmentative communication device. They will continue to communicate orally, even if they're not being successful, because of that drive to be socially accepted. And of course, when this process happens, you see that they get extremely frustrated when peers or adults fail to wait to understand the message. So if they get interrupted, etc., or that they simply get left out of the conversation or walked away from. So there certainly is great need, but there's limited research. We also know LSVT loud is treatment dependent, and so we see that neuroplasticity occurring in the pediatric context as well. And this occurs when it is intensive task repetitions, as we see in the LSVT programs, progressive challenges to the learner with increasing difficulty, which certainly the hierarchies will check those boxes, that there would be a presence of motivations and rewards that are internally driven. And of course, the saliency that we're always targeting, certainly that is met in LSVT. It's very active in its participation. We see skill acquisition of functional goals, and that it must be structured. And when we think about reinforcement in the pediatric populations, even more so, you're going to be prioritizing the intrinsic reinforcement of success. And so make intrinsic rewards 90% of the session. Only use those like stickers or turns playing a game or those little tokens, you know, that we give to kiddos when they're completing repetitions. Only use those types of extrinsic rewards as needed. Otherwise, save them for when the child is really failing, which happens more so in weeks 2 and 3. And work. They don't need nearly as much external reinforcement and external rewards as we tend to give other populations.
So it's the other Heather again, and I'm going to finish up the rest of this webinar talking about some more of those adaptations. I think we've done a great job in talking about the need for rests, for decreased reps, for using the family members, specifically for LSVT loud, what Heather mentioned before, persisting at the phrase and sentence levels. You know, the other thing you want to think about is altering the materials. You know, the things that we have downloadable for you as certified clinicians may not be the best for certain patients. So you might have to think about new ways of presenting those. I think the importance of really spending more time shaping people, right? They're going to need more touch. They're going to need more information for you. When we're doing things for modeling, it might be that we're doing them for shorter durations, right? That they're not having people to walk for super long amount of time or for talking for a very long amount of time. And again, for the LSVT loud, it may be that we're focusing on the shorter functional phrases. Keeping it simple, we have said that, both my Heather and myself, even when they have other communication deficits there. And we can't say this enough, but really acknowledge their fatigue. Let them know, hey, we get how hard it is and we're really working with you to help. Now, what LSVT adaptations are not is any kind of altering of the core protocol. We don't want a change from how we deliver things to be fewer or shorter sessions. We don't want to be changing the treatment tasks. We want to keep to the same because, again, repetition helps with neuroplasticity. We don't want to eliminate any of the core elements, meaning that, yeah, what is our target? We're working on that amplitude. We don't want to refocus our attention elsewhere. We don't want to do one thing one day and then skip it the next day and come back and do it again. And we have to remember, these folks, even in advanced stages, even with less of a cognitive reserve, we have to give them more of the practice. So we have to make sure that we're assigning those carryover assignments. So what do we know with everything that we've done out there? What does the research show us? What do we know anecdotally? We know that people with advanced PD absolutely have the ability to learn new things and that they can improve the quality of voice and movement. That being said, the improvements may be smaller in magnitude as compared to someone that we see very early on in the diagnosis. Treatment will probably take a little bit longer, and know that people might need us for longer. There really is as Heather said, a solid rationale for using LSVT loud in childhood populations. And we do have some really good emerging evidence across patient reports for acoustic, perceptual, physiological, and neural data that really do, again, help us to support the use of LSVT loud. So remember that there is hope. Don't underestimate the value of therapy. Just because the condition is complex or the patient has non-idiopathic PD, always give it a try. Remember the stimulability testing, try it 4 times a week for a week. These folks really, they can have really amazing outcomes. You might be the first person to come along and actually give them some hope and help for betterment. Functional communication and movement of any kind, remember, that's just going to give people a dramatic improvement in their quality of life. We just got to give people a chance, right? Don't discount successful treatment options just because things are hard. I mentioned the stimulability, and remember that functional oral communication of any kind can dramatically improve quality of life, just like Heather said, even if we need to give an extra supplementation. The same goes for safe functional movement. We can improve that even if they need some help to be held onto, to use an assisted device, or to have someone externally cueing them. So in summary, remember that these LSVT treatments absolutely can be applicable to different stages, and you can customize them and adapt them to the needs of your patients. Our goal is to really increase independence, quality, and safety with communication and the movement. If we can restore function, improve function, and maintain function, boy, have we done our jobs. We know that the atypicals, the advanced, and even some people post-DBS really do have unique challenges, and you're going to have to be creative to really help that patient to be involved and to help that care partner and caregiver to equally be helpful. You know, think about how you're making decisions, be systematic in that, think about your stimulability trial, and then think about, you know, maybe this is the best course, maybe this isn't. You're going to have to put on that clinician cap. And again, we say embrace creative, practical implementation. Don't diminish the fidelity of the neuroplasticity and that brain change, or diminish the evidence-based practice that we have by alternating things. We want to keep to that core protocol, and that's how we know we're going to see the most improvement. So as I said before, you have the ability to ask questions. Heather is going to read those from the chat box for us. If we do run out of time, you can also feel free to email your questions at info@lsvtglobal.com. And if we do have leftover questions in the chat, we will make sure that one of our experts reaches out to you and we get those questions answered. So we want to thank you for your time. And again, our apologies for that glitch at the beginning. But again, you do have those handouts as a reference point, and we're happy to answer any kind of questions that you have. So I'm going to turn this over to Heather and see what we have going on.
Great, fantastic. And we have one question that came in. Before we answer that, I'll just remind and reiterate a survey will launch when you have logged off. And so we appreciate any feedback, certainly. I know it was frustrating with the technology today, so our apologies for that. We'll be in touch as to the on-demand component. We'll check and make sure both segments were recorded, and if not, we might do a little fix so that that beginning content is included. I don't know the answer to this, to be honest with you, so Heather, maybe you do. But Robert, your question about AOTA and whether or not this can be used for the purpose of CEUs. You're absolutely right. These aren't registered or pre-approved CEU activity, but I know like for speech pathologists, this could be a self-report continuing education activity. Heather, I know, I don't know if you've learned from our OTs at all, but
I think it's also a self-reported activity. So most people are getting these as self-reported and not having any problems. So if you do have trouble, let us know, but most of the time it's working out for folks.
Great. And then someone did weigh in and said it depends on your state. So thank you so much, Melissa, for weighing in on that. Depends on your state. Where she happens to be, it does not require AOTA pre-approval. So yeah, I would look into your state in the self-report aspect of CE reporting. And other than that, that was our only question. If questions do arise, as my wonderful co-presenter mentioned, you can email, you can look at the website. There's FAQ sections there as well. And then any questions that you have, yes, there will be a certificate for the webinar. That question just came in. It can take a couple weeks for that to get processed. So, and if you were here for the whole hour, even if you were not able to hear the beginning, we'll honor that, absolutely. Same for those of you that have to sign off, since we are at the top of the hour. You'll get credit and a certificate will be produced. For those wanting or requiring a certificate for self-report or for your own records, feel free to reach out as well to info@lsvtglobal.com, and we can absolutely make sure that you get one there. So, and thank you so much, Dina. We're glad the handout is helpful for you. That's great feedback. We really appreciate it, everyone. And I think that wraps it up for feedback and for questions. So it's been a pleasure to be with you today. Heather, it's been a pleasure as always to co-present with you. I always learn so much on the aspects of LSVT big. And so have a great rest of your day, everybody, and email or contact us otherwise if questions arise.
Take care, everyone. Thanks for your time.
Thanks.